Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Greetings. Thank you for joining us for this live webinar to help you prepare for upcoming changes associated with the implementation of the Patient-Driven Groupings Model. Today, we will explore how an assessment of clinical operations can provide opportunities to ensure a successful transition to the new payment model while also optimizing patient outcomes. My name is Molly Casey. I'm on the marketing team here at Axxess. Before we get started, let me tell you a little bit about Axxess. We are a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their businesses while making lives better. Today, you will hear from two industry experts. First, I'd like to introduce Karen Vance. Karen is a senior managing consultant with BKD, where she has been delivering clinical and operational services to home care providers since 2003. Karen also provides reimbursement and compliance consulting services and helps home care providers establish and maintain quality management practices. With home care experience dating back to 1981 as a provider, clinical, and regulatory manager, Karen has presented home care seminars for over 30 years for national, state, and regional healthcare associations and industry media organizations. Also joining us is Rhonda Ralph, clinical support specialist for Axxess. Rhonda works with Axxess and our integration of Home Health Gold, providing training and consultation on the use of Home Health Gold's data analysis and reporting features. Formerly, Rhonda developed proficiency managing home health and hospice services from staff nurse to director of clinical services with a Maine-based home health agency. With 28 years of nursing and administrative experience in the industry, she's been able to support operational managers with expert analysis. Before we get started, just a few housekeeping items. Everyone's phones are muted. However, you may submit questions throughout the webinar. We will follow up with you after the webinar to answer any questions you may have submitted. Following this webinar, we will provide everyone with a link to the slides and post a video recording of the webinar on our website at axxess.com. Rhonda, over to you.
Great, thank you, Molly. So today we're going to provide a brief overview of PDGM and cover thoughts and processes to consider while preparing for the transition on January 1st, 2020. That's only 4.5 months from now, folks. A little scary, but preparing now will certainly help ease that transition. So let's start with a brief overview of PDGM. Hopefully at this point you are all somewhat familiar with the structure of PDGM and the components that impact the HERG score. We have two 30-day billing periods within a 60-day episode. The clinical documentation or the OASIS requirements have not changed under PDGM and will continue on a 60-day episode cycle. With PDGM, the admission source considers where the patient has been in the 14 days prior to the home health admission. If the patient has an acute or post-acute care stay within 14 days prior, this would be considered an institutional admission source. If not, this would be considered a community admission source. With timing, the first 30-day period is classified as early. All subsequent 30-day periods in the sequence, second or later, are classified as late. A sequence of 30-day periods continues until there is a gap of at least 60 days between the end of one 30-day period and the start of the next. When there's a gap of at least 60 days, the subsequent 30-day period is classified as being the first 30-day period of a new sequence and therefore would be labeled as early. In PDGM, each 30-day period is grouped into one of 12 clinical groupings based solely on the primary diagnosis, which is and should be the primary reason for which the patient is receiving home health services under their Medicare home health benefit. The 12 groups were designed by CMS to capture the most common types of care that home health agencies provide. The number of therapy visits are no longer applicable, but the functional level scoring remains and is determined from the OASIS time point. All other components that I mentioned or are mentioned are gathered from your claims. A comorbidity is a medical condition that exists in addition to the primary diagnosis, and they are generally tied to worse health conditions or outcomes, more complex medical needs and management, and generally higher care costs. In these situations, additional dollars are allocated based on a low comorbidity, which is a single diagnosis from a CMS list, or a high comorbidity, which is triggered by a pairing of 2 diagnoses from a CMS list. So let's touch upon some of the key components. Your primary diagnosis drives the episode of care. You want to be sure you use only PDGM diagnosis. It must be an acceptable diagnosis that falls into one of the 12 clinical groupings. Questionable encounter codes are the #1 threat under PDGM. That's where agencies are losing the most money when you look at their data today. Questionable encounter codes are not reimbursable, and that applies to the primary diagnosis only. CMS will deny claims with questionable encounter codes. You will have the opportunity to correct and resubmit, but that could end up affecting your cash flow, so you want to get it right on the front end. These codes are generally ICD-10 codes that are unspecified, or symptom codes, those that begin with an R, such as gait instability, muscle weakness, or repeated falls. So you want to be specific. Are there tools to assist you in identifying your questionable encounter codes within your EMR? You may want to consider coding partnerships, outsourcing your coding if you do not have certified coders on staff. You also may want to consider those that you work with or partner with. You want to verify that their staff are trained and up to date on all the latest in PDGM. Educate your referral sources regarding the need for the detailed information on the front end. You're going to need this information in order to be able to code with more specificity. Your comorbidities, depending on the secondary diagnosis, the care period may receive a comorbidity adjustment. There are 3 levels for comorbidities. You have none, where the diagnosis that you enter will not trigger additional dollars, and you have low and high. Payments for your low comorbidity could increase dollars per episode by about 113, and for your high comorbidities, about 339. Now, that's an average. There is variation from clinical grouping to clinical grouping. Your admission and timing, you want to be sure you're gathering as much information as possible from your patient as well as your referral source. Develop a checklist of required information to obtain on intake. Having this information will certainly streamline your submission process. Your functional level, the information for the functional level is retrieved from the OASIS using the current functional questions that we do today under PPS, with the addition of M1800 grooming and M1033 risk of hospitalization. There are 3 levels for your functional score, low, medium, and high, which may trigger additional dollars for the episode of care. And functional severity can account for up to a 24% increase in your revenue. So it's important for your clinicians to get those questions right on the front end. Your LUPA thresholds, they vary for each payment group and are per 30-day payment period. They range anywhere from 2 to 6 visits per 30-day period. Managing LUPAs, you want to consider scheduling in a 30-day period to help prevent any unnecessary LUPAs. Assure there's timely documentation and tracking of missed visits. Good things to be on top of on the front end. A good thing to do is verify that your EMR is ready to tackle PDGM. Within Axxess software, we provided tools for our clients to use today to analyze their data, the impact of PDGM, and identify changes necessary for a successful transition to the new reimbursement structure. We have the PDGM modeling tool. This tool gives the client an opportunity to see what their reimbursement will be under PDGM. It's a great tool to use as part of the intake process to identify how the patient will present. We also have the case mix analysis tool. With this tool, we give the client the ability to see their PPS versus their PDGM data. You can also see your LUPA thresholds for each 30-day period. In addition, this tool will identify questionable encounter codes just in case the agency ignores the ICD-10 alerts, which we have available through intake. So what are your steps for a successful transition into PDGM? If you haven't already, plan now. There's still some agencies who have not given any thought to PDGM, which is quite frightening to me, considering the amount of change that's going to happen. You want to hold your leadership accountable for results. Meet with your leadership regularly. Watch your timeline. Have you completed a gap analysis on your agency? You want to set your goals and adjust them accordingly. Analyze your data to determine where action is needed. Know your numbers. Where is there risk for your agency? What are your top 10 diagnoses? Are they questionable encounter codes, and what's the dollar impact under PDGM? How will you address coding going forward? What's your current LUPA rate? How will you manage LUPAs effectively under PDGM? Will your EMR track this information and alert you in real time? What are your average days per episode? If they're less than 30, how will this impact your reimbursement under PDGM? If you discharge your patient at day 28, you will not receive reimbursement for that second 30-day period within the 60-day episode. So you want to question, are you discharging your patients too abruptly? Some clinicians have the habit of discharging a patient as soon as the goals are met. Maybe you want to consider decreasing your frequency and following them through that 60-day period, which I think is good care. Of course, you will have to discharge them if they're no longer homebound, but it's good to follow through. When you're absent for a week or two and return, it's quite evident, or you're able to identify where the patient didn't have a good understanding or they didn't follow through. And hopefully that's going to help with your rehospitalization rates as well, and maybe even your patient satisfaction, because it's good care. Your number of visits per episode, your utilization. Are you efficient with your care while demonstrating positive outcomes? Your outcome measures, you certainly want to track your numbers to ensure they're not declining during the transition. And in regards to utilization, you will no longer gain additional dollars for the episode of care because of your therapy involvement. But therapy remains critical to ensure functional gains and positive outcomes. According to a study published recently in the Journal of American Medical Directors Association, 1 to 2 PT visits can help lower the chances of rehospitalization among older adults by up to 82% in a 60-day period. So therapy continues to be vital as part of your care team. Referral management or electronic referral platforms may be very helpful. They allow a uniform, seamless transfer of patient information from one provider to secondary providers. It supports speed of communication, enhanced decision-making, and transfer of information that assists in delivering quality care. They will be very beneficial under PDGM. You want to assure there's tight controls for productivity and missed visits. Productivity, will help you, having productivity standards will help you keep your costs down. Or if people aren't meeting the standards, it's good to drill down to identify why are they not meeting the productivity standards? Do they need assistance with how they're performing their work? You want to be sure you're managing your LUPA rates. We've already touched upon that. Be sure your EMR is able to track those for you. Your OASIS accuracy, your functional questions are key. Historically, under assessing the OASIS questions has been an issue in the industry. You want to make sure you educate your clinicians on the importance of accuracy and why. It has a direct impact on your outcomes and your reimbursement. Your coding accuracy, of course, we touched upon that, very important to be sure your primary diagnosis falls into one of the 12 clinical groupings. With your comorbidity diagnosis, you want to ensure you have supporting documentation for the codes you have entered. Certainly CMS will be keeping an eye on that. And again, consider outsourcing if you do not have trained coders on staff. Your capital reserves during the transition, it's always wise to be prepared for cash flow issues. If you all recall, or those that were in the industry back in 2000 when OASIS was implemented, there was a lot of agencies went out of business. They were not prepared. So you have an opportunity to prepare today. With your, with your roles in your agency, consider how things will change under PDGM. How will it impact your employees' ability to do their job? What changes need to occur for each position from the front end to the back end. You want to analyze their daily activities to identify where processes may be streamlined. Communicate and communicate some more. Be clear with your expectations. Keep the lines open. Keep the lines of communication open with your employees. Monitor progress. Use your data to guide your decision making. Base your actions on quantifiable metrics. Do you have the tools to monitor your progress under PDGM? There are plenty of opportunities to thrive under PDGM through education, action, and successful management. You want to plot your plan. What needs to happen within your agency? Your importance of staff education, that can't be reinforced enough, especially with the OASIS. Accuracy will have a direct impact on reimbursement and outcomes. Consider using a PT to teach regarding the functional aspect of the OASIS to improve accuracy and consistency across all disciplines. Consider completing inter-rater reliability visits with your clinicians. Where are they doing well? Where can you provide some education or thoughts regarding how they're completing the assessment in the home? I think it's very wise that clinicians have a good understanding of PDGM basics and the cost of care compared to the revenue generated. The importance of accuracy in the details need to be stressed. Understanding the whys under PDGM will allow your clinicians to have a better understanding of the importance of accuracy in the details. For more detailed information and educational materials on PDGM, please visit our Axxess PDGM Resource Center. It's a wealth of free information accessible to all in the industry and well worth sharing with your staff. There's some great tools to help in the education process, so please check it out. Axxess is ready for PDGM, and we have the tools and resources to share with you. So I'm going to hand it over to Karen now, so she will talk about some of the best clinical practices.
Thanks, Rhonda. That was quite an overview, a lot of information in a very short period of time. What we want to do at this point is take a number of things that Rhonda mentioned as she was going through the overview and hinted at some of the things that you might want to be doing as an agency to get prepared. But let's go into a little bit more detail about what that's going to include. From a clinical operations perspective, here's a summary listing of things that will be greatly affected by PDGM and what you can do to prepare for managing that impact. This is just kind of a repeat of some of the things that Rhonda already mentioned. Clinical operations impact on PDGM accuracy is going to rely heavily on accuracy of admission source and admission timing, the accuracy of clinical and comorbidity groupings, accuracy of functional scoring, LUPA management. That's kind of a tricky wicket to be prepared for, but we're going to talk about some strategies for that. Looking at visit utilization over 2 30-day periods instead of just one 60-day period, as well as the elephant in the room, and that is appropriate use of therapy services. So let's talk about what each of these things can look like. We happen to believe that there are 3 primary categories that you want to be focusing on in terms of developing strategies for managing your PDGM impact: interdisciplinary care, patient-centered care, and clinical management. We're going to be talking about the importance of the interdisciplinary care approach to collaboration for OASIS accuracy. We've known for a long time that OASIS is supposed to be a single clinician tool, but it was only recently that it was finally put out in writing from CMS that it's fine. It's just fine to collaborate on that accuracy, and we'll talk about how that can look. We also want to make sure that you've got collaboration for diagnosis accuracy. Care coordination for visit utilization. So we just flipped from making sure you've got accuracy for proper revenue versus utilizing your visits for expense management. And then lastly, again, utilizing interdisciplinary care planning to assure that you're getting appropriate therapy utilization. Patient-centered care is not just making visits, not just managing visits, not just ensuring that your visit frequency matches your orders, but we want you to think in terms of managing episodes, full episodes of care, not just making visits. Patient-centered care also is better managed using what we're going to call a primary clinician role or a case management role, if you will, instead of having a variety of different people in the same discipline seeing a patient, that you've got more consistency and care continuity in dealing with the patient and knowing where they are in their episode and their progress toward their goals. Patient engagement in self-care or in self-management has enjoyed a lot of notoriety in the literature in recent years as the primary way to help patients, particularly with chronic conditions, to manage their own condition. And let's face it, our top 4 diagnoses in home health are chronic conditions. So we need to make sure that we are helping patients engage in their own self-management. We also believe that doing so means we've got to taper our frequency of visits so that we're not just seeing the patient along and it's all about us laying hands on the patient, as opposed to them getting involved in their own plan of care. We'll talk more about how tapered frequency can assist that. Then lastly, clinical management is very key. Clinical managers, clinical supervisors, whatever the title is that you're using in your agency is going to be key as it's kind of the gatekeeper for managing the PDGM impact. Facilitating accurate revenue drivers, making sure that we know that we are getting the most accurate payment for the patient that we are providing care for. Management of expenses, the other side of that margin equation. Clinician accountability as well as key performance metrics so that you know whether or not you are holding your clinicians accountable. Let's talk about each of these items in a little bit more detail. Start at the beginning, pursuing accurate information. Admission source and admission timing is one of the first pieces of the PDGM model that Rhonda provided an overview for you. And you have what we believe are 3 opportunities to get it right, starting with intake. First of all, we know intake, the role of intake is going to be probably a little bit more substantial as it has been in the past. The intake department or person, depending on the size of your agency, is going to be responsible for obtaining as much information as possible to get that admission source and timing correct, to make sure that we've got good confirmation of diagnoses and documentation to support whatever diagnosis that we choose for primary, as well as, of course, the face-to-face encounter documentation, which that piece is not going to change, of course, with PDGM. But we're going to recommend that if you're focusing on this kind of information that you're needing to get from your referral source, if you have the ability to, and I know we've got a lot of people on the call that are from all over the country, and you might be from rural areas, you might be from smack dab in the middle of a major metropolitan area, and those kinds of scenarios might make a difference in what you have available to you. But if you can, if you're in one of those situations where you've got access to portals where you can pull information, as we just listed, in order to know that you've got the right information that you need from the referral source, instead of insisting on them pushing it to you. Here's the key. yes, we've got to make sure we get all this good, accurate information, but you got to balance pesky pursuit of all this information with keeping the referral sources happy. We all understand that there's been a lot of people out there saying you need to go out there and educate your referral sources. You know what? They really don't much care about what's happening to us in home health and don't particularly feel that it's their primary responsibility to understand it all. All they want to do is get that referral off their desk at 3 o'clock on Friday afternoon. Everything you can do to help them with that while making sure that you get as much information as possible is our responsibility, not theirs. So do what you can to keep them happy. Remember, it's all about relationship development. The second place you have the opportunity to continue to drill down and make sure that the information you've gained so far is as right as possible, and that's during the admission. So build it into the admission process, the person performing the comprehensive assessment, that they're confirming with the patient or caregiver the source of their referral or where they've been in the last 14 days. You may have gotten a referral from a physician's office. Doesn't mean the patient hasn't been in the hospital within the last 14 days. So we all know patients are the best historians, right? Right. Well, at any rate, whatever you can do, look for cues in the home for discharge packets, see if there's a caregiver around that can be helpful in confirming some of that information for you. Second step in that, let's make sure everyone in your agency that is admitting a patient is documenting that piece of information in the very same place. We need to make sure that everybody who needs that information can find it quickly and easily without digging for it. So that's one piece you can do to help your billers a lot. Also remember, even though we've gotten a lot of information at intake and we've gotten information from the referral source about the reason for the referral, etc., the primary reason for home care that we put in M1021 is derived from a thorough comprehensive assessment. So you may have a good process in place where you've got some front-end coding getting started, and all that's great. But be careful that you don't rely on only what's provided to you from the hospital, because it could be the comprehensive assessment in home health provides some additional insights into what's going on with the patient that best explains the reason for home care. Now, it may be that somebody out there in a comprehensive assessment says, oh, I didn't see this anywhere in the referral packet or the H&P, but man, this sure looks like it's a major problem. Or the most obvious example I've used in the past is no documentation anywhere that this lower extremity ulcer is a stasis ulcer, but it sure looks and smells like one to you. So you may want to confirm that. Doesn't mean you can't go back to the physician and say, this is what I saw. What do you think? Lastly, our last opportunity to make sure we've got this information down correctly is at the billing point of this revenue cycle. Confirm that the accurate episode timing is in the common working file or other websites as needed. Make sure that you compare that with other clinical record documentation to ensure that you do have it right. Whatever got passed down to billing from intake needs to be confirmed with admission, the admission nurse or clinician, to make sure we've got the right information down. And then make sure it's coded accurately on the claim. Admission source, admission timing, and the diagnosis codes, because if we don't get it on the claim, it's not going to matter that it's accurate on the ERASIS. So that's starting the whole episode off. We're right at the beginning, and during intake and admission, we're making sure that we're getting as accurate information as possible. Then our next step is, how do we utilize interdisciplinary care conferencing to really up the ante and make sure that we've got as accurate information as possible? We believe that interdisciplinary care conferencing is the way to do it. And when we say interdisciplinary, that means care conferencing or coordination between the disciplines. We know a lot of agencies have care conferencing where individual disciplines might call in to their supervisor individually, and that individual clinical supervisor is kind of the holder of all the information. But if you're not letting these people communicate and coordinate together, it's not true interdisciplinary teaming. So keep that in mind, how you get it done, and there are lots of ways to do it, whether on one end of the continuum you've got all your people in the same room at the same time, versus having a virtual care conference where people still are able to communicate. It's up to you how you want to do it and how it's best for you. But let's make sure that this kind of collaboration does occur, because at the beginning of the episode, that collaboration is going to be key to making sure that your OASIS diagnosis as well as your OASIS data are as accurate as possible. So the functional scoring, as we have seen over the last 20 years since we've been doing OASIS, and all the OASIS accuracy assessments I've done in my time, those functional scores are the ones that are the biggest culprit for having some inconsistency between what we see in therapy documentation and what we see in what the nurse has scored the OASIS in. So if you have, theoretically, in the same room or however, the opportunity to have a consensus discussion between what nursing saw, what therapy saw, and guess what the aide saw. Aid in contribution to OASIS data accuracy can really make a difference in what people see early on in the episode. So let's make sure that you've got an opportunity and a mechanism for getting that collaboration to occur between everybody who laid eyes on the patient. You also, at the beginning of the episode, want to make sure you've got the most effective and the most efficient plan of care. In other words, you have the right people doing the right thing, and no more and no less. Let's make sure that we don't fall into that age-old problem home health has had for decades, and that's why we've always called parallel play. You've got 2 or 3 different plans of care going on in a parallel fashion, but never the twain shall meet. Got to make sure that everybody understands going into it what the plan is, what they expect the patient to be able to do, and how you're going to reinforce each other in terms of the plan of care. Care coordination at the beginning of the episode is very key, particularly when it comes to trying to reduce hospitalization risk. Can we, instead of necessarily front-loading nursing visits, if we've got a blue plate special, and we got nursing in and a couple of therapies, home health aide, and if you're real lucky, a social worker, can we make sure that somebody's in the home every single day within those first 2 weeks, instead of necessarily adding more visits, which would reduce your cost efficiency in that plan of care, but still get really good outcomes? As long as everybody knows, what are we doing to reduce this hospitalization? What's putting this person at risk, and what are we going to do, every single person that walks in that home, to mitigate that risk? That's what we mean by care coordination. Interdisciplinary care conferencing at the 30-day period is going to be very important going into PDGM. What's the progress toward outcomes? Does the plan of care need to be changed? Are there barriers to the progress? Is there a change in the primary diagnosis? We all know that the second 30-day period can have a change in the primary diagnosis on the claim. If that's the case, is it as accurate as it can be? And do we have substantial documentation somewhere in the chart to support that change in the diagnosis? We all know that CMS said we don't have to do another OASIS, but you better make sure you've got good documentation. And then at the end of the episode, if you're a clinical supervisor, challenge. If somebody plans to recertify a patient, challenge. that recertification by asking them, what are you going to do in the second cert period that you didn't get accomplished in this one? If they plan to discharge, challenge that discharge and ask them, is this patient really ready for discharge? Are you just documenting one time that they returned demonstrated or verbalized understanding? Or did you give them time? Did you give them space between visits to demonstrate to you that they really have incorporated their new skills into their daily routine? When you're taking a look at the possibility of discharging someone, take a look at the OASIS and ask yourself, if I was going to do a little quick down and dirty drop and run OASIS right now in my head, take a look at just those OASIS items that are really key to this particular patient and ask yourself, how would I score them? If I was going to do an OASIS today, how would I score them? And looking back to the last OASIS, did they decline, and does that surprise me? The most important part about that phrase is, does it surprise me? We all know we've got patients that are going to decline. But if it surprises you, then either A, maybe it's not time to discharge, or B, maybe we better go back and take a look. Did we collect that data as accurately as possible in the beginning of that episode? Managing diagnosis selection and coding accuracy is very key to this process. Understand your clinical groupings, as Rhonda said. Make sure you avoid those questionable encounters. Make sure you've got coders that know what they're doing. We worked with an agency one time that we were kind of doing a preparation training, and they said, yeah, we've been saying we need more coders. But after we took a look at their analysis, I said, nope, you need different coders. So let's make sure you've got coders that truly understand what they're getting into and know how to avoid those questionable encounters. Collaborate on the primary diagnosis and the comorbidities. Make sure you're discussing among you the reasonable and necessary reason for the patient's condition, and is it represented in the listing? Assess for change in that second payment period, and let's make sure somebody's on it, that we know where that documentation is to support a change for that second 30-day period, and confirm that support in the documents. So all of that is going to be necessary to make sure that you've got as great an accuracy as possible for your ICD-10 coding. Can't emphasize enough what you can be using an interdisciplinary team for to prepare for PDGM. When you are looking at, number one, collaborating on OASIS, data accuracy, and ICD-10 coding, what you're doing is ensuring your best revenue, your most accurate revenue. But at this point, we're talking about what can you do to also make sure you've got the most cost-effective plan of care. Make sure you're using the generalized skills that every discipline has to reduce duplication. As I mentioned before, instead of unnecessarily adding nursing visits just to go in and take vitals and make sure they're taking your medication, if indeed that's the reason for those visits, make sure you understand all the disciplines that you can rely on to go in and do the same thing and report to each other when they see something that's outside parameters. Optimize the unique skills of each discipline and make sure that you are truly utilizing them to the best of their ability. I mentioned that the top 4 diagnoses we have in home health are chronic conditions. Rhonda went through the clinical groupings briefly. There's one thing that we are greatly chagrined by in the development of those clinical groupings, and that was the fact that they tacked on the word rehab at the end of 2 of those groupings. And I am so concerned that sometime in June of next year, somebody's going to say to me, well, yeah, that patient wasn't in one of those 2 groupings, so we can't have therapy on there. That's not what it means. Therapists have very unique skills. However, I will say in effort in the last 20 years of using therapists as ATM machines, we've kind of gotten lazy as therapists. And I apologize if I'm offending anybody, but I read a whole lot of plans of care that's nothing but muscle strengthening. And muscle weakness is one of those questionable encounter diagnoses that will not be able to be used anymore. And there's so many skills that therapists have that's got nothing to do with muscle strengthening that really can help these patients with chronic conditions and in all those MMTA groups. So go back to your therapist and have a conversation about what can they be doing to help a patient with COPD or CHF, energy conservation, pursed lip breathing, a lot of those tools that I haven't seen in the documentation for quite a while. Then collaborate that care to optimize the outcomes. Make sure your clinicians are talking to each other and really utilizing a good combined approach to this patient care. And remember, the patient is the most important member of the team, and let's make sure we're utilizing that. And that's where we can really focus on patient-centered care management to get engagement on the part of the patient. Focus on the patient's priorities. Lo and behold, after I can't tell you how many decades, finally the COPs say, you're supposed to ask the patient what their goals are. Well, maybe since it's in a regulation, people will start doing that more often, but it's really important to find out what's important to the patient and make sure that they understand that when we're doing these things on the plans of care, that we're really working on trying to get them toward what it is that's important to them. So get their participation and their engagement. Encourage what we call in-between visit progress by the patient. Get them involved. We know we have them keeping a weight chart and they're doing a home exercise program, but how often do they really follow through with that? Can we up the ante in impressing upon them that this is their job to participate in the plan of care? When we get more participation by them in between visits, guess what? They make more progress because it's not just progress while we're there making a visit. Focus on the progress toward outcomes, not just visit compliance. We have a real heavy weighting towards making sure that we're complying with COPs. But, and that's not saying it's not important, but there are a lot of times people are focused more on compliance with COPs than progress toward their outcomes. If indeed the patient is making progress toward their outcomes, consider taping their frequency earlier in the plan of care than what you had originally planned in order to give them the opportunity to do more and for you to back off. I mentioned earlier that we feel like continuity of care is real critical in patient-centered care management. One primary clinician per discipline. I know that's not possible to keep it to just one and only one, but try to reduce it, improve that continuity of care. We know from research that continuity of care is the single biggest patient satisfier. The primary clinician model means that that primary clinician or that case manager performs the bulk of their own visits in coordination with maybe one other clinician. Autonomous self-scheduling for managing those visits, so a person can manage their own schedule and their own calendar, move things around so that they can do their own admissions. It's a priority to perform, if you're a case manager, to perform your own comprehensive assessment and OASIS data collection and develop your own plan of care. So it may be necessary to separate the initial assessment to allow the case manager to perform their own comprehensive assessment, such as our agency average of over 40% of all of our admissions happening on the weekend. It's kind of hard to make sure that case managers are doing their own comprehensive assessment. So maybe you have the person on the weekend just performing the initial assessment. Go back to the COPs 44.55 and read the difference between the initial assessment and the comprehensive assessment. Patient-centered care management, as I said, I think I went backwards instead of forwards. Care coordination means front-load care, not just visits. I gave an example earlier. Reinforce each other's education. Ask each other, what have you asked the patient to do that I can reinforce? Collaborate and coordinate. Don't just communicate. I know a lot of agencies that say, oh yeah, we have interdisciplinary teaming, We give report to each other once a week. Well, that's not necessarily coordinating what you can do. Think about it. If indeed you're reinforcing each other's education to the patient, the nurse walks in and says, the therapist says that you've started increasing your activity, that you're getting up and walking at every commercial break, and that you're doing a lot better with that. That's great. Can I see how that works? Or the therapist walks in, or the aide walks in and says, can I see your med box? Did you get your meds taken today? What's going through that patient's mind? Oh my gosh, they're in cahoots. And if they think that you guys are talking about them behind their back, then the chances are much greater that they might actually do what we have asked them to do in between visits. Manage care by the episode. Like I said earlier, don't just manage them by the visits. Yes, we have to follow orders. I get that. But there's so much more to care planning than just making sure that the frequency is met. So make sure that you're looking at the whole episode of care. Where's the patient going? Not just how many visits have they made, but are they making progress to their outcomes, and what can we do interdisciplinarily, if that's a word, to really make sure that we're all getting that patient marching forward toward that goal. Make sure, as I mentioned earlier, that we've got the right skill mix for the best outcomes. Let's not fall into old habits of just thinking that we have to have 3 separate plans of care, but maybe there can be some fluctuation between frequency of the disciplines to make sure that we've got the right person doing the right thing. Effective patient engagement, as I have mentioned. Disease management and best practice tools are all over the internet. How cool is that? So go out and find those things and incorporate them into your plans of care as a team, as well as integration of telemonitoring or remote patient monitoring. Great way to really be cost effective with your visits, but also making sure that the patient truly understands that when you say, let's keep this weight chart and understand what it is that increases your weight when you bump up 3 pounds overnight, and you don't have to be out there making a visit to know whether or not the patient is truly managing their own condition. So these are a list of things that I would like to see you keep handy to think in terms of what can we be doing to truly get good care coordination. Assess those unplanned LUPAS. We know we're going to have about, I think it's around 9% is an average LUPA percentage, LUPA rate across the nation in our agencies. But so we know that you're going to have some, but let's make sure the planned LUPAs, like your once a month catheter changes and your B12 shots, make up the bulk of those. But it's the unplanned LUPAs you want to be watching for. Do you have good known strategies to reduce hospitalization before the number of visits? The problem with the LUPAS now, it is a moving target under PDGM, so you can't rely on knowing exactly how many visits you have before it turns into a LUPA. Have we truly matched the patient's clinical picture with their visit utilization? Are your unplanned LUPAs a result of missed visits, staffing issues, patient not homebound, patient refusal, scheduling issues? See what you can do to assess and see where your trends are. If you've got a lot of LUPAs, I was working with an agency one time, and they had one clinician in particular who had a lot of LUPAs, and it was every single patient that was really far out of their normal, typical service area, and lo and behold, it was a one visit only evaluation. So see what those trends are and see what you can do to manage those unplanned LUPAs. Does the patient really require more visits to meet their goals and improve their outcomes? Were the right disciplines added during the episode to get the best clinical outcomes? Managing LUPAs is something that you can also do to help with that second 30-day period. On the top, you've got a 60-day certification period. Remember, our certification periods are still 60 days. So we do an OASIS at the beginning, And at the end, typically at the beginning, we're front-loading visits and tapering them toward the end. But under PDGM, we've got a full 30-day payment maybe if we front-loaded visits on that first 30 days. But if we haven't tapered the frequency, what happens then when you only dip into that second 30-day period and your agency average at this point in time, as far as length of stay is concerned, is like 33 days? Take a look at that same number of visits and how well can you taper them and take them out, spread them out over the 2 30-day periods. So number one, you reduce hospitalization. Number two, you get better outcomes out of the patient because they're doing more and you're doing less. And three, it reduces the possibility of LUPAS in that second 30-day period. So the byproduct of interdisciplinary care is accurate payment through accurate data collaboration, effective use of payment through coordinated skill mix and efficient use of visits, and tapered frequency of all disciplines to reduce visits with the patient engagement and coordinated care, and to reduce LUPA risk with visits drawn out of over 60-day period. And look at that. It's the right thing to do anyway. Nobody's going to argue against interdisciplinary care. And if these are the things you can get, that's even better. Align productivity standards with your agency drivers. Consider a caseload productivity standard rather than just a certain number of visits during the day or during the week. Remember, the patient is the only revenue producer, so you don't want to necessarily just increase people's visits as productivity. You want to increase their incentive to add patients to their caseload. So if the caseload expectation is what you're expecting from them, it aligns with your agency driver for an increased census for better revenue. Make sure they understand that case management activities and care coordination is included in that. Episode management, as we've mentioned before, for better clinical outcomes as well as financial outcomes, outcomes improvement, and OASIS accuracy. All of these things, not just the number of visits they make in a day or a week. Tell them you're watching all of these things about their performance. So what that brings us is to your ability to measure and monitor and manage your staff. Measure your performance by clinician by good key performance indicators. Monitor their performance with benchmarks to see where they fall. Communicate to them what their performance is with dashboards and scorecards. Make it objective. Focus your education on your poor performers and your poor outcomes. Don't take a shotgun approach and just talk to everybody at the same time. Focus on just those people that really need it the most. Then manage your accountability. And then you've looped right back around to continuing to measure to see whether or not their performance has improved. What are some of those key performance indicators? We've got here a sample of a cascading dashboard that can be used for accountability. Take a look. On an individual clinician level, if your software can provide these numbers for you, that's great. If they can't, see where you can get your hands on them, even if you need to pull some data elsewhere. But individually, each clinician, you want to watch what their case mix weight is, what their LUPA rate is, what their caseload is averaged over a quarter. We know it fluctuates way too often from week to week in home health. How many new patients did they take in a quarter? What was their average visits per patient? What was their rehospitalization rate? And then what are the outcomes that your agency is targeting by your QAPI team based on your CASPER reports and your QAPI process? These are the numbers you want to be watching on an individual clinician basis, but they roll up to either a team or an agency level. So what's your average case mix weight per team, your average LUPA rate, so on and so forth. Then your clinical manager or administrator is looking at all of this as well at an agency level on a monthly basis or a quarterly basis, And so when that payment, your per patient payment goes up or down, your clinical manager should be able to go back to either the team or the individual clinical supervisor and say, what's up? What gives with this? Why did our average patient payment go down? Then that clinical supervisor goes back to her individual numbers and says, ooh, that new nurse didn't quite get the mark. Maybe we need a little bit better education for her on her OASIS data collection. That's what we mean by cascading. Every number on your chief financial officer's monthly financial report can be translated to clinician behavior, and that is what is your responsibility as a clinical management team to be able to then influence those numbers. With that, I'm going to pass it back to you, Rhonda, to let you wrap it up.
Wonderful. Thank you, Karen. So your RCM, do you have, or does your EMR support checks and balances required in order to submit in a timely manner? Basically, your billing processes are going to double under PDGM, so it's a good question to raise. Having an automated system that ensures all orders and required documents are dated and signed will certainly save time, improve your cash flow, decrease your overhead, and help improve your compliance. With AxxessDDE, we have a platform that streamlines operations and decreases your cost and increases your revenue. We have daily real-time claims reports. You can manage your claims from one simple dashboard, real-time eligibility checks. It's an automated claims correction platform that ensures faster reimbursement for you. So we are ready for the PDGM billing cycle. And with AxxessDDE, we are putting you first. We provide a direct access to the common working file to query the most up-to-date information in a nice, clean format. It's a full mobile access product to use anytime, anywhere, accessing your information in real time. It allows you to get paid faster, ensures compliance, and spend more time focusing on patient care and improving your outcomes or your 5-star rating as well. So it's a system that is certainly going to help improve your cash flow overall and save time. With marketing, just a few points about marketing. You want to strengthen your marketing position through your outcomes, track and trend your data, share this information with your referral sources, use your liaison activities for coordination of care, for care plan oversight with your physicians to allow them to bill for minutes allocated. Consider adding specialized programs. CMS determined that the cost of care for agencies is higher to take care of certain patient types, so payment was adjusted accordingly for wound and dementia diagnosis, as well as your complex nursing cases. Under PPS, these cases were considered somewhat undesirable as they were costly and more likely resulted in a loss of revenue, and many agencies declined taking them. But under PDGM, if managed effectively, they can be revenue generators, more desirable cases that you may want to accept as compared to your past practices. So look at the programs you are offering. What changes may be beneficial to your organization? So that is the end of our PowerPoint, and I am going to just check in with you, Karen. Is there any additional input or insight that you would like to add?
No, I think we got it pretty well covered.
Wonderful. So I'll hand it back to you, Molly.
Thank you, Karen and Rhonda, both for sharing your wisdom and your insights to help us prepare for the implementation of PDGM. Just a reminder for everybody on the webinar, we will provide you a link to the slides and the video recording. We will send that out via email. It is also something you'll be able to access on our website, axxess.com/PDGM. I did want to share real quickly with you, we are going to be hosting day-long seminars in markets around the country this fall. I'm delighted to say that both Karen and Rhonda will be joining us for some of these seminars and be presenting and sharing their expertise. at an even deeper level. If you or anyone in your agency is interested, you can visit axxess.com/PDGM/seminars. We would love to see you at any one of those. And thank you for joining us today as we continue to deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a wonderful afternoon, and thanks so much for joining us. Bye-bye.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.